device patient. And this is the introduction, as you have heard about the implantation of the valve becomes now an established technique all over the world. And we did a lot of cases in Egypt, and in our National Heart Institute we did about 23 cases during the last 2 years, and we stopped temporarily because of the new building designs and the refreshment of the National Heart. I'll start first by the vascular complications, which is a very important issue, and it has a slightly higher mortality if you have major vascular complications. So, for the first time, you have to avoid the complication and not to treat it, because this is has a very prognostic impact. You have to anticipate where is the problem, because if you have a calcification or a narrow vessel in the common femoral external iliac or the common iliac, and a lot of calcification, you have to expect that you might have a dissection or perforation at this segment. You have to know your anatomy well by the muscle CT, as has been described by Dr. Yes and Dr. Ahmed, and know how to treat the complication, not to wait for the vascular complication, to wait for the endovascular specialist. So we always say that you have to have some experience in peripheral intervention to avoid these complications and to treat it. You have to have some peripheral equipments, like the balloon, self-expandable stents, covered stents for the perforated segments if you have a perforated artery, endografts and surgical instruments. Of course, these are mandatory. There is a technique you have to start with during the procedure of the TAVI, the crossover balloon technique. You have to put a wire from the contralateral side into the other side, and this should be ready for any dissection or perforation at the site you are introducing the device. Like this case, this is the management of the major vascular complications. You have to be ready with the crossover wire and balloon, and you put your stent to cover the perforation, but unfortunately the video is not working. And also surgical exposure. A vascular surgeon or a cardiac surgeon should be available in every case, and this is the concept of heart team. The guidelines for vascular perforation: if you have a proximal injury, contralateral balloon occlusion, aortic or iliac, ipsilateral covered stent, if complete disruption in the vascular for retroperitoneal component or surgery in the groin. If you have a distal injury, manual occlusion if feasible, and contralateral balloon or stent. So, the final thoughts: careful pre-procedural screening and meticulous procedural technique will improve procedural results with transfemoral TAVI. Understanding limitations of current systems, important for patient selection and anticipate where problems may occur. Crossover wire aids in rapidly managing complications. Fill-out equipment is readily available, and start familiar with the issues. To have good outcomes, appropriate screening and patient selection, improve lower profile devices, and now we have Sabian 3 low profile, and Evolute R from Medtronic have also low profile devices, so the vascular complications become less than before. And also, and this is very important, experienced team regarding the operators. These are the two valves, and here the outcome in 16 studies, about 3,500 patients. You can see the vascular complications, vascular events at 30 days, 11.9%, these are the measure. Bleeding at 30 days, 15%, measured life-threatening bleeding of 15%, and measured bleeding 22%. These are very high percentage of complications in this series. If we look to the vascular complications, the classification, 62% are vascular dissection, vascular perforation in 31%, 22% access site hematoma, 9% retroperitoneal bleeding, false aneurysm in 3.4%, and gastrointestinal ischemia in 1.6%. There is also an association between the major vascular complications, bleeding, and renal failure. You can find there is higher incidence of renal failure with major vascular complications. These are the sheath size here between the valve in Sapien 23, Sapien THV, the first one, first generation, was 22 French. Sapien XT, 18 French, and you can find later on Sapien 3, 14 French, as well as the Revolut R. This is the difference between the Sapien and Sapien XT regarding the size and complications. You can find the difference between the Sapien XT and the Sapien, the other one. Here, this is the Sapien 3 sheath size. You can find here for the 20 millimeter valve, it's 14 French, 23 millimeter, it is 14 French. The Sapien 3 can accommodate 5.5 millimeter size of femoral, and for 23 it's 5.5, while the Sapien XT 6 millimeter foremost. The lower profile valve and delivery system is associated with low rates of mortality, stroke, and access site complications. What can we do to prevent them? Appropriate screening, as I said, techniques, US guided puncture or angiographic guided puncture, as you've seen. This is the Edward sheath. I will go rapidly for this. In the summary, patient selection and increased operator experience are key. Smaller delivery system and sheaths will improve outcomes, and adjunctive techniques help to control and manage catastrophic situations. A stroke is one of the complications. You can see the difference between surgical and transcatheter. You can find there is difference, significant difference between the surgical, 12% and 8.8% for the TAVI. The major strokes also, there is lower incidence with TAVI. And this is 1 year. Also, there is good, significant difference between both. These are comparison between the transapical versus transfemoral, nearly the same, 2.8% to 2.9%. Prevention measures, carotid pressure at the time of advancing the sheath to minimize pulse dilation is very important. Emboli prevention devices are recently developed, Claret device, umbrella device, and Trigard device. Here are the shapes of these new devices. These are the Claret Sentinel device. You can put an umbrella to protect the common carotid, the right side and the left common carotid, and this is Edward umbrella, and they have good results recently. This is a Trigard. I don't like to go into more details. So, to minimize the stroke, you have to use the protective device in special situations. It is not a routine work, you have to do it in some special cases. Regarding the paravalvular leak, it's very important after TAVI. This is a frequent problem regarding the regurgitation, and it might be considered the Achilles heel of TAVI. It ranges from mild, moderate, and severe. Mild is accepted, while moderate to severe have a negative impact on the prognosis of patients regarding the mortality for those patients. What are the causes of paravalvular leak? Valve positioning, annular sizing, annular anatomy, calcium, asymmetric distribution of calcium, and prosthesis choice. Here are the sealing zone of both valve and sealing area. You can have cross-section through multiple areas for sealing for LED outflow tract. The distribution of calcium is very important, and this also the same. The etiology of aortic regurgitation, either number one, prosthesis patient mismatch due to undersizing. Two, incorrect size of implantation, either too high or too low will introduce the paravalvular leak, or incomplete expansion of the valve. These are the morphological distribution and annular sizing, and these are the degree of aortic regurgitation. The projector of moderate to severe TAVI valvular aortic regurgitation. This is the France. In self-expandable device are more. And this is a very important trial that has been done by one of our colleagues from Shanks, Dr. Kamal Abdelhab. The choice trial, he had a comparison between the Edwards valve, balloon expandable valve, and the self-expandable. 121 patients were randomly assigned to receive balloon expandable valve اللي هو الإدوارد CBLC, والجروب الثاني كان إدوارد كور فالف. وفي نهاية الستادي دي الحقيقة قال إن ما في difference في cardiovascular mortality at 30 days بين التو valves. Bleeding with vascular complications ما كانش في significant difference between the two. في combined safety endpoint. لكن in the placement of new permanent pacemaker was less frequent in the balloon expandable valve group. كان 17 إلى 37. يمكن النسب دي اتحسنت مع الجلود R والسيرين 3. ويمكن شفنا آخر devices recently الفالف محاط سكيرت علشان يقلل البارافالفولار ليك، ولكن ده كان على حساب البيرمننت implantation of pacemakers لانه بدا يحصل complete heart block اكثر maybe due to the material itself or due to over compression. How to manage the rationale for post dilation balloon expandable stents. بنعمل redilatation برضه post dilatation في السيلف expandable عشان نقلل البارافالفولار ليك. وبالتالي احنا عندنا مشكلتين كبار، كان البارافالفولار ليك والستروك يعني about to be او nearly solved بالprotective devices newly developed devices اللي هي محاطه بالسكيرت عشان نقلل البارافالفولار ليك. هيفضل عندنا مشكله يمكن كبيره بس هي very rare اللي هي aortic root after rupture. عندنا 4 types of annular rupture: supra-aortic, supra-annular, annular, sub-annular, and combined. ويمكن ده inevitable complication and can be managed well if it is diagnosed early. وبرضه can be prevented by proper sizing and proper management of the patient. Thank you very much.
Your presentation as usual. I have 2 questions, please. The first, what is the role of anticoagulation? What is the protocol for anticoagulation and platelets after TAVI regarding vascular complication is the most common? The second question, what is the incidence of effect in carditis and what is the best treatment option?
Yes, thank you. Regarding the anticoagulation, we are using sometimes, in most of the cases, dual antiplatelets, and we have cases we have used only aspirin for those patients. We've done 23 cases. More than 90% of those cases receive dual antiplatelets, and they continue for 1 month, and then continue on aspirin alone. And we have 2 patients, they have platelet deficiency and they did not receive even aspirin for some time, and then we resume aspirin. The second question regarding infective endocarditis, we don't have any complication regarding infective endocarditis. It's a very rare complication.
I think عشان الوقت احنا بنشكر الدكتور حمدي طبعا على المحاضرة القيمة دي، و I think in the session